Hi, my name is Beverly Ann Trevino, and in our Safety Council meeting today, I will be talking about a plan to manage aggressive patients. Our objective here is to hopefully reduce overall use of restraints and identify de-escalation strategies for patients with exacerbation of mental health conditions. Restraints are often used as a primary approach to manage aggressive patients, which does have negative consequences. It disrupts the therapeutic relationship between patients and healthcare workers, influences patients' decisions to receive future health care, and then has physical and psychological harm. Data here shows 40% of restraint-related deaths were caused by unintended asphyxiation during restraint use. We all want to note guidelines for the management of aggressive behavior in patients with mental disorders recommend the use of de-escalation as the first method of choice. We also want to note Hawkin et al. 2013 found a reduction in incidence and duration of restraints after the use of multimodal interventions, which included de-escalation techniques. Now that we know what the literature says and what factors are important, I'm going to talk about the plan I am proposing to manage aggressive patients. I am proposing initiating de-escalation techniques to diffuse aggression. Richmond et al. 2012 did a systematic review of the literature and found that across these studies there are 10 domains of de-escalation techniques. One is respecting personal space, so maintaining those 2 arms of length of distance and then staying near exits. 2 would be do not be provocative, so watch your body language, hands should be visible, you should be appearing calm and non-confrontational. 3 is establishing verbal contact. There should be only one person trying to de-escalate. Remove those bystanders, introduce yourself, provide reassurance, and be polite to the patient. 4 should be being concise. Use simple, short sentences. Give the patient time to respond, and then you can repeat your messages as necessary. 6 is listening closely to what the patient is saying. So active listening, clarifying statements, and accepting that what the patient is experiencing is their truth, especially for patients who are experiencing delusions. 7 is agree or agree to disagree. You may not agree with everything. You can agree that the patient is experiencing the delusions, but you may not be able to agree on other things. So agree to disagree. 8 is lay down the law, set clear limits. Tell the patient that injury to staff or himself is unacceptable. Say this as a matter of fact, not in a way as a threat. Treat patients with respect and coach patients gently. I need you to sit down. I need you to help me understand calmly, but calmly tell me your concerns, but I need you to sit down. 9 is offering choices and optimism. So you can offer choices like blankets, magazines, phone calls to family members or friend to help them calm down, food or drinks, but do not make them false promises. Let the patients know that they will get better, they will improve, and that staff wants that for them too. A lot of patients say, I want to get out of here, I want to discharge, letting them know, I want you to discharge as well, but I want you to do that safely, and we want that for you. And then lastly, debrief with the patient and the staff. With staff, you can debrief in seeing what interventions worked, what didn't. And with patients, you can dive deep in their perspective. What works for you when you are upset? What can we do in the future to help you? So how would this be implemented? This timeline I'm proposing is over the course of 10 weeks for phase 1, staff education on the 10 domains, and then doing those educational sessions. Phase 2, we'll be selecting 1 unit to observe over a 2-week period. We'll do reminders of the techniques on badge cards, the break rooms, posters, stuff like that. And then we'll do feedback boxes for staff or emailed surveys for staff to evaluate implementation. Lastly, taking lessons learned from the pilot unit, we'll implement this across all units, do the visual reminders again, and then do the daily huddles and debrief incidents or near misses, and then monitoring the fidelity and implementation. So phase 4 will be our evaluation and ensuring sustainability. Step 1 is looking at the effectiveness of the interventions. Are we seeing a reduction in restraint use? What does the data say? Step 2 is looking at the fidelity of the implementation. So are staff members adhering to the techniques? What's their confidence level? Step 3 will be reviewing future planning. So we'll have discussions with unit leaders, safety council members, update the protocols and policies. And then for the future and during unit orientation, onboarding for new staff, we can teach them these de-escalation techniques. We can also put this into our performance reviews, are staff still adhering to these techniques, and then do monthly refreshers or in-service training for all staff members. At this conclusion of our evaluation, our goal is to have a better understanding of how to handle these incidents while reducing restraint use, and then hopefully improving patient outcomes.